Hi, Assalamu alaikum and good morning everyone. Thank you for visiting my channel again. Abdurrahim here with you. So we are continuing our aortic regurgitation topic. Yesterday I gave you an overview about the aortic regurgitation patient, like how you are going to start the patient. Today I'll explain you the main things. What could be the etiology of the aortic regurgitation, like what could be the main reasons of the aortic regurgitation, how we should look at the aortic valve, what is the anatomy of the aortic valve, something about the aortic root, okay, these things. And then we will also try to go into the quantification of the aortic regurgitation, okay. So different parameters. I will explain you first, like how I used to do. I will explain you first, and then I'll show you a presentation in which they will be showing like how we are going to do it, okay. I'll explain you with the presentation as well. So first about the aortic, if we talk about the etiology, so the main thing is first we need to know about the aortic valve. Aortic valve is consist of three leaflets, okay, right, left, and non-coronary cusp. If we go into the, like if we consider it the short axis view in transthoracic images, so you will see the right coronary cusp just beside the right ventricle. Towards the pulmonary artery you will see the left coronary cusp, and towards the right atrium or towards the left atrium is known as the non-coronary cusp. So these are the three cusps. You see it in parasternal short axis view. In parasternal long axis view you see only two cusps. One cusp, the upper one, okay, towards the right ventricle is the one, the right coronary cusp, and the one towards the left atrium is the non-coronary cusp. So this is for the exam wise for the students. In parasternal long axis you will see only two cusps, right and non, and in short axis you will see all three cusps, okay. So that's one thing. So aortic valve is consist of three cusps definitely, and also you will see the three commissures, and then the annulus line which is consist of the fibrous tissue, okay. Then this is the aortic valve itself. Then you can have the abnormalities within the aortic valve, like it could be a congenitally bicuspid is more common. Then you can have a unicuspid valve, and then the quadricuspid valve as well. So these are the examples of if there is something wrong with the aortic valve leaflet, congenital defect, then we can have a prolapse of the leaflet or a flail leaflet of one of the leaflet, and then you can have the the myxomatous changes of the leaflet. Then you can have endocarditis. So these are all related to the aortic valve issues. So if any of these things happen, then you will have the aortic regurgitation, and the reason would be either prolapse or myxomatous or endocarditis or these things. So you will mention it, so anyone who is going to treat the patient will know that this patient is having a prolapse of the valve or whatever the reason. So you give the etiology, okay. As I told you in the last vlog, that once you talk about the etiology, then you will be also giving a hint towards your regurgitation jet. Because for example, if you are saying about a prolapse, so any of the leaflet is prolapsing, the regurgitant jet will be going opposite to that prolapsing leaflet. For example, in the long axis view, when you are having two leaflets, this is the right and this is the non-coronary. So for example, non-coronary cusp is prolapsing this way, so your jet will be going towards the septum, okay. And if your right coronary cusp is prolapsing, your jet is going towards the mitral valve, because your mitral valve is here. So the jet will be opposite to the direction of your prolapsing leaflet. So this is one thing. And then the other abnormalities which can cause aortic regurgitation are the abnormalities related to the aortic root. So any sort of dilatation in the aortic root can cause aortic regurgitation as well. So there are some diseases which can cause aortic root dilatation. Hypertension is most common, then Marfan's, and then there are some of the some other diseases, connective tissue diseases. They can also cause the aortic root dilatation or aorta dilatation. Even in bicuspid aortic valve you can also have the dilatation. So these are the main reasons, but for the echo wise we need to look at the dilatation, okay. So how we measure the aortic root, that is also very important. If we went into the aortic root, it gives us this type of appearance, okay. This is the leaflet, and then this is a hinge point here, okay. you see the two hinge points there, they are your sinus of Valsalva. Okay, so these two are the sinuses. Then you see the, you know, a sign comes in like this. Okay, this is your sinus, these two are your sinus, and this is your sinotubular junction, and then the aorta starts from there. I would suggest, like, when we take the normal parasternal long axis view, we usually don't see very good root and ascending aorta. So I most of the time I usually go one space up to measure my aortic root and ascending aorta. So I'll show you in images as well, like how I used to measure. So in different books it's mentioned differently. In, like, for BSc, they say that wherever you see the full opening of the root, you should measure it. But ideally what we used to do before is that we measure the aortic root at end diastole, just before the opening of the aortic valve. You will measure the sinus and sinotubular junction, and for the ascending aorta, I usually notice that we measure it in systole when it's open better, but in some books they mention it to measure it in diastole. But most of the cardiologists or most of the guidelines say that you measure it wherever you are seeing the bigger size and clear size. For the technical point of view, you need to go one space up where you see the ascending aorta proper, you will measure it there. Okay. So this is your mainly the etiology. If any of these are dilated, for example, sinus of Valsalva dilated, sinotubular junction dilated, ascending aorta dilated, which later on can cause aortic dissection. So these are all causes of aortic regurgitation. So you need to mention if there is an aortic regurgitation and also dilatation of the aorta. Sometimes you will have maybe a very normal aortic valve with significant aortic regurgitation, or maybe just mildly thickened aortic valve with severe aortic regurgitation. So the reason could be either sinus of Valsalva dilated, or full aortic root dilatation, or the ascending aorta dilatation. So you need to mention these things in your report, almost in every report, but especially in aortic regurgitation report. So I think we are done with our etiology part. Now we will go towards the quantification of the aortic valve. So once we talk about the quantification, there are different methods. But I'll just go one by one. So once you start from your long axis view, the first method which comes in mind is that you put the color in and you will see the regurgitation jet coming into the LV. So you can zoom it and you can measure the vena contracta. Vena contracta is the smallest portion of the jet, just after the leaflets. Okay, if you remember, when I was telling you about the mitral regurgitation, I told you that every jet has three components. One is the flow convergence, where we measure the PISA radius. The second one is the vena contracta, and third one is the body of the jet, or the body of the jet mainly, or the width of the jet they call it. Anyway, so the first two are the main important one. Okay, so you will measure the vena contracta. Once you are going to measure the vena contracta, there are some points you need to keep in mind. One is that you need to zoom it. Okay, zoom your image, decrease the color box just for your aortic valve, put it there. Okay, and see the jet. Once it just jet coming, whenever you are going to measure the vena contracta, try to make sure that you are seeing all three components of your jet. Like, you are seeing the flow convergence, you are seeing the vena contracta, and you are seeing the body of the jet as well. If you are seeing these things, it means you are in good position to measure it. Then zoom it and freeze it, and slowly move it wherever you see it better. Just measure it. Okay, and vena contracta, once you are measuring, another very important point which I see most of the sonographer do the mistake is that they tend to decrease the baseline to get the vena contracta. This is wrong practice, and you are going to overestimate it. Okay, you don't need to change your scale or your baseline. Your scale would be around like 55 to 60, which is recommended. Okay, usually the machines have 60 or 61 or 58, so you will measure it in the same scale, and don't decrease or increase the baseline. You are not going to do the PISA radius. Decreasing or increasing the baseline is related to PISA radius. Okay, So keep in mind, in vena contracta, you don't need to decrease or to do anything with your baseline. Just zoom the image, freeze it, slowly move it. Wherever you see better vena contracta, measure it. Now, there are in aortic regurgitation, especially, most of the jets are not very much central. If the jet is central, you can get a very good vena contracta. But if the jet is not central, then it's very tough to measure the vena contracta. You can give it a try still, but it's gonna be wrong most of the time. But still, vena contracta, you can try it. And if there are multiple jets, then you don't need to do vena contracta. Or if you just want to get a hint for yourself, just get the vena contracta of the bigger jet, just to make your mind, but don't document it, as it's not reliable in those patients. Then the next parameter is the jet area width of the LVOT. So what you do is put the color there, okay, and put the M mode on the color, okay, in LVOT, and then you get the LVOT. You will see this type of LVOT going, and the jet will be going between this way, okay, the regurgitation jet. So you will measure the jet definitely in diastole, okay. So you will measure the, for example, the area. For example, your not area, you get the diameter of the LVOT, for example, it's 2, and you get the regurgitant diameter, for example, it's 1, okay. So it means you have 50% covering. It means it could be significant. So if your jet is covering more than 60%, it means it's a significant aortic regurgitation. Again, this is if the jet is quite eccentric, then this is not reliable as well. You don't need to change your baseline or color scale for this one as well. Same color scale. Then you get this point. Another thing which I see most of us usually miss the trick in these cases is that, as I said most of the time, that aortic jets are not usually very central jet, okay. They are either going to one side, maybe on the towards the septum, or towards the mitral valve, okay. So in parasternal long axis, if we see, this is our parasternal long axis, so the jet would be coming this way or going to this way, okay. So if you are having this sort of jet in parasternal long axis, you can just align your jet, just move your image to make the cursor align, and you can get a very good Doppler. I have done like multiple cases where I did all my PISA measurements in the same view. Parasternal long axis, I get a very good radius, okay. I just decrease the baseline, because in this way the jet is coming to this direction, so I just decrease the baseline and I get the PISA radius, then I get the velocity, and my PISA was done in the same way. And also the regurgitant volume, when I trace the jet, I can get the regurgitant volume. So my PISA calculation was done even in the long axis view only. But yeah, and sometimes you can definitely try it in the apical views as well. You go into the apical views, try, and if you don't get it better, you can come back to it. But I'm just giving you a hint that usually we think, oh, we are not aligned in long axis, so we don't put the Doppler. Always try to do the Doppler. Even in aortic stenosis patients, always try to take the higher parasternal long axis view on the left side. I'm not talking on the right side. Put the Doppler there. Most of the time you will get the higher velocities, like the right parasternal one. But anyway, this is it. So this is another way. So the next way to calculate, to quantify aortic regurgitation is the PISA method. You know how to do the PISA method. Just get the PISA radius first, okay. How you will get the PISA radius? Remember the rule of thumb I told you. You need to take your baseline towards where your regurgitant jet is going. If jet is going upwards, you will take the baseline up, okay, around 39, 40, 38, that range. And if the jet is going this direction downwards, so you will take the baseline down towards 39 to 40, okay. This is you will take the PISA radius, then get the Doppler. You need to align the Doppler. Another very important thing, I wish I could have the examples, but I don't have, but I'll show you the examples next time if I get one, is that when we put the Doppler on aortic valve, sometimes we get a very good signal, but actually that signal is not correct, because if we see the peak velocity, it is around 2 or maximum 2.5, which doesn't make sense, because the aortic and LV pressures are quite different, unless the LV pressures are significantly high. That's another thing. But even in normal cases, like someone is showing mild AR and everything is fine, and if you look at their Doppler, they measure the pressure half time and everything very well. But if you look at the Doppler peak velocity and you see only 2.5 or maximum 3, doesn't make sense, okay? Because the pressure difference should be high. So you might get a velocity of 4 or 3.54 in diastole. But again, you need to keep in mind that you need to get a good Doppler signal, try to align it and to get it, okay? So you will do your PISA method, and then I will tell you I'm intentionally not mentioning the parameters, like how much the PISA radius should be, or how much I'm not mentioning the numbers, okay? I will show you on the computer later on. So PISA is another method to quantify aortic regurgitation. Then the next method is a Doppler signal. You need to look at the Doppler itself, like how sharp is the Doppler signal. Usually in aortic stenosis, aortic regurgitation patient, you will get very sharp signal because you will be aligned. So that's another way. And then you need to look at the pressure half time. This is a very tricky thing. You can have a low pressure half time, like giving you an impression of severe aortic regurgitation even with the mild aortic regurgitation, okay? And sometimes you can have almost a mild or mild to moderate aortic regurgitation pattern from pressure half time, okay, with a severe aortic regurgitation. So you need to understand the way of pressure half time. Pressure half time is actually it gives us the pressure difference between aorta and LV. So keep these two things in the mind. Yes, when the aortic pressures will with the severe aortic regurgitation, the pressure half time will decrease, but it gives us an impression that the LV pressure has gone up, okay, and now the LV and aorta pressures are equalizing very soon, okay, very quickly equalizing. So that's what we get from the pressure half time. So it could happen in two ways. One is that actually the aortic regurgitation is very severe, so it's as soon as the diastole starts, a lot of flow goes from the aorta to the LV, and the LV pressure goes sky high, and we see the very steep pressure half time, which gives an impression that that there is severe aortic regurgitation. And sometimes what happens is that the aortic regurgitation is not very severe, but LV pressures are very high due to some other diseases. Maybe there is significant mitral regurgitation, or there is severe LV dysfunction, or LV diastolic dysfunction, which is the LV diastolic pressures are already high. So if LV diastolic pressures are already high and there is mild or mild to moderate aortic regurgitation coming as well, so that will also increase the LV pressures. So you will see that steep flow of pressure half time again, that steep slope. So that doesn't mean that the aortic regurgitation is severe. It means LV diastolic pressures are very high. That's why we are having the low pressure half time. It's a bit complicated one, but you will learn this thing when you will be continuously doing it. So you will understand it, what is the phenomena between pressure half time. But I would suggest that two things you need to keep in mind. Once you are tracking the pressure half time, look at the other parameters which can cause LV high filling pressures, and also look at the other parameters of aortic regurgitation as well. If other parameters of aortic regurgitation are not suggestive of severe aortic regurgitation, then you need to pay attention that whether it's severe or not, okay? Like, don't only rely on pressure half time. So the next is I call them indirect parameters, or the one we see the reversal in descending thoracic aorta or abdominal aorta, or some of the people, they do right femoral arteries to look at the flow reversal. So that's very easy one. You just go into the arch, okay, and put the color on the descending aorta. You will see the blue flow which is going in systole, because your probe is here, so the flow is going away from you, okay? Actual flow is going away from you because the arch and descending is going downwards, okay? So the systolic flow will be blue, and then after the systolic flow you will see a red flame coming towards you, okay, towards your probe. That is actually the flow reversal. So if you see that red, some people does, you know, put the color there in M mode and try to get that one. That is also a very good way to do it, but you can put the Doppler in and get the reversal. Keep one thing in your mind, which most of us, even myself, we do this mistake, and that once you are putting the Doppler in your descending aorta, so you are going to see the reversal. So reversal is going to come above the baseline. That's the first point. What we do is we put the Doppler in descending thoracic aorta, okay, and our baseline is just touching very high, and we are only seeing the flow down the baseline, which is the systolic flow. If we need to see the flow reversal, we need to bring our baseline down so we can see the flow above the baseline, which is our reversal in diastole. That's one thing. Second thing is we are looking for a diastolic flow hollow diastolic flow reversal. So we can have a very small reversal in early diastole. That's normal, no problem. But if you see a full diastolic flow reversal, it means there is aortic regurgitation. And then when you are getting that flow, you need to decrease your scale, because you are talking about, you know, 2 millimeter, 5 millimeter of the flow. You are not going to have a very high velocity flow. You are going to have very low velocity flow. So you need to decrease your scale to see that flow better. Okay. Sometimes what we do is we put the Doppler there, we do everything right, but our scale is very high, so we don't see any reversal there. Keep an eye always that you need to decrease your scale to look at the reversal. Okay. And then the same thing you can do it in abdominal aorta. In abdominal aorta, you will see the flow reversal above the baseline, down from the baseline, below the baseline, sorry. In abdominal aorta, your flow reversal will be below the baseline, and your you know, the systolic flow will be above the baseline. Okay. So this is how these are the different parameters to assess the aortic regurgitation. And now I will show you a presentation. It will be just an overview, the same thing as I told you already. And I will tell you the numbers as well, like how much the vena contracta should be for mild, moderate, severe, and how much the other parameters would be. Okay. So let's come on to the presentation on the computer and I'll show you there. Thank you. Bye-bye.